morning, everybody.
Good morning, Pat.
Yes, I'm standing in for Lawrence Newman, who can't be with us this morning. So we're going to do go around the table with our feedback from the 15 Steps Challenge. And on my list, in fact, it's Peter, Aruna and I went to B5. So Aruna, would you like to begin?
Yeah. We went to B5 and So we went to B5 and actually also into C5, which is the escalation piece of B5. So starting out, I'd say very clean, actually. So that's a real positive. We felt that was really clean. I think the overwhelming message is staffing. They were running at 60% staffing. All bar one was supply staff. No band 7s. Only one band 6, so really stretched from a staffing perspective. So I think a lot of what I'm going to say is probably a reflection really of, or a lot of it is a reflection of running a full ward on 60% staffing. So there was a lot of medical equipment that was just around the ward. On entry to C5, one of the clinical rooms was open. One of the beds was broken really in B5. A gentleman wanted to be lowered, but when the matron came in to lower the bed, she realized the bed was not working. There was no one at reception desk. Then the board in B5 was not filled out. It was completely blank. No names at all on the board. What else did we have? I think that was most of it, unless Peter or Pat want to fill in any further.
So I think everyone I spoke to, whether they were members of staff, patients, the cleaning team, everyone's observation was actually how stretched they were to provide the care they wanted to provide or to receive because of the staffing pressure. So that was the overwhelming feedback. The other element that I heard was good team working, even from the temporary staff who were on. They felt welcome and part of the team, and they were clearly keen to provide caring care. They all wanted to do more, but were limited by the number of patients they needed to cover between them.
Yes, I mean, I would absolutely echo that. The patients that I spoke to were lacking in some things which are just to do with staffing, so the call bell wasn't answered very quickly and things like that. But I would like to say that on C5, which is an escalation area and the beds are close together and there are some quite a few patients clearly with dementia, the staff were looking, as they were looking after one member of one patient, they were looking at another patient who they were concerned about, and there was a lot of active monitoring, even though they didn't have the numbers to do it as effectively as they clearly would like to. And I did notice that one nurse who moved from a patient she was giving a drink to try and make sure that another patient who was getting out of bed didn't hurt themselves, she still managed to wash her hands in between, to gel her hands in between the two patients, which I thought was very good under that sort of pressure. So the next was Richard and Ian and Lisa, and you went to B6.
Okay, thank you. We spotted on the entrance to B6 the hand gel wasn't working, so it was empty, so we reported that and they were very swift in doing something about that. When you enter B6, you're not quite sure what to expect because remembering we're early, so there's nobody on reception. Reception doesn't open till 9, runs from 9 till 4, so it looks a bit empty. But you quickly get the feel of it was very calm. It was very clean. There was a lot of, it felt like there was a lot of clutter about, but there wasn't. It's literally the size, I think, of the corridors and the way in which that ward is configured. These are patients who should be almost ready to go home. We saw a lot of patients that potentially weren't going home very quickly, and when we talked to Anna, the nurse in charge on the ward, she said that they do suffer from patients staying longer than she would like. We spoke to a couple of really lovely patients who spent quite a lot of time talking to us about how brilliant the care was, how the nurses took time to make them laugh and engage with them. We saw a lady, they were up out of bed, she was doing puzzles. So we did see quite a lot of people up having breakfast, watching telly, and doing puzzles. We were very impressed, I think, with the electronic whiteboards that we saw. That looked really great with all the information on. We saw staff using the handheld information and the laptops. We did find drugs cupboard that was open. It was shut, but you could open it. So it just wasn't locked. So we did highlight that. When we spoke to some of the staff, their biggest issue or the biggest thing they were saying was around the staffing. They were doing their very best, but they, that sometimes they struggled with staffing. And interestingly, and I know we can't do anything about it yet, but when you come out of that ward and you go downstairs and come back out of the ward, you see the most horrendous wall where water has come through and paint is peeling off. We can't do anything about that, we know, because of the... But it doesn't look that good as you're a relative coming off that ward.
It just really brings it home in terms of the disastrous state of the infrastructure.
No, I was on a different visit. I was meeting
I mean, the only other thing, I mean, it was clear. I mean, Lee's had a couple of quite extensive conversations with patients, and they're desperate for that social interaction. They're desperate to engage with people, and that was the thing that struck me as well.
Okay, I went to C3, so along with colleagues. So stroke ward, and on stepping onto the ward, I think there was an air of calm efficiency on going on. It looked clean, but it was, in common with a lot of spaces, very cluttered. So every available wall space had a piece of freestanding equipment beside it, and if you'd wanted to wheel a bed into or out of the ward, you'd have had to have moved a lot of stuff to get it past. And the staff we spoke to echoed that they felt the physical space was difficult in terms of being able to see beds that had unstable patients in them, the nursing station, visibility from it, relatively limited. Looking at the patients that were there, again, it all looked under control. The patients looked comfortable. Patients I spoke to seemed happy with their care and comfortable in the environment. Coming back to the space again, we witnessed the ward board round, which was taking place at the nursing station, which of course is not an enclosed confidential space, and there really is nowhere on the ward to have confidential meetings, and the therapists echoed that as well. And it's just a limitation of the facility that they've got there. They'd mitigated it as well as they could, so they'd closed all the doors for the single rooms there. In reality, there was nobody that shouldn't have been there in the meeting, but theoretically it was there, and picked up the issue of whiteboards in the corridors where you can see, patient identifiers there. And there's nowhere else to put the whiteboard in that environment. Coming to staffing, it looked like a functional team working under pressure through shortage of staffing, and everyone we spoke to said that shortage of both nursing and medical staff was a significant problem. Talked about delays in getting trainee medical staff to come and clerk new patients who'd arrived, and also a comment that obviously there have been problems with consultant recruitment in the stroke service, and that had been difficult in terms of consistency of leadership. But they seem to be functioning, mitigating that. They just observed that made their job a bit more difficult. So overall, I think there was a functional team that had managed to make the best of the environment and the staffing levels that they've got. I don't know if anything to add.
I think the only thing, turning on, I think staffing was quite the obvious concern when we spoke to staff. But I think the challenge that we had was that actually even the therapy staff are saying that they're prevented from doing therapy work because they're actually having to support the nursing, so the physical nursing of our patients as opposed to providing that therapy. So, and whether that's some of that work, that seems to be HCA level as well. So I think that's something we need to try and explore. But actually, when we did explore them, they do feel that their managers are listening and working with them. I think they felt a bit concerned about some of the stuff that they're reporting on our incident data, the DATEX system, some of the low-level stuff. That they don't feel it's getting any further, so they report hundreds of low-level, no-harm instances, but they don't necessarily feel that there's it's going onto the risk register or being picked up as a common theme. So I think we probably need to work with the director on are they picking up common themes and a number of lower-level instances.
Thank you. Martin, that was your first look around. Did you want to comment about anything? Martin, we'll introduce you properly in the next bit of the meeting, but...
Yes, just to emphasise a couple of things. The whiteboards I thought were really impressive bit of technology, but I did notice that it's got things like date of birth and some of the medical information on it as well. So I was thinking about from a data privacy and GDPR point of view. But I realise that a lot of that comes back to the issue about space and not really having anywhere else to put them. And the specific concern I'd have about the amount of equipment which was in the corridor is simply the trip hazard that a lot of it creates, just by the basic design. There was also a specific about one of the hoists not working and a replacement had been ordered, but that seemed to go back to August and there seemed to be some delay in terms of replacing the equipment that the nurses were concerned about. But the impression in terms of the huge commitment and positive kind of team spirit of the staff, I know, it's very impressive.
Thank you very much. Thank you. Daniel, you and Martin went to...
Mary Moore. Do you want to go for it?
Yeah, sure. Staffing actually looked quite good on Mary Moore. It was tidy considering the time of day. The environment of the patients is now much better than when it first opened with all the remedial work completed. Overall, we found staff approachable, friendly, talking to the patients, and we did identify there was a problem with the whiteboards, and that was backed up by our patient flow nurse who'd just come down, I think, from Heathrow, where patients are being discharged on IPM, but it's delayed on the whiteboard, so we wasn't sure if this was the main issue or not.
Sorry, I'll take that back, because that shouldn't happen, because it takes data from IPM. It's not a separate system. So I'll pick that up, just to follow through the details, just in case there's some kind of glitch.
Yeah, that's the impression we got. I think that was it. Thank you.
So we met a member of the swoop team, so that's someone who's currently employed by the Royal Marsden for the community services, and we said, so are you excited about Sutton Health and Care starting on the 1st of April? And she said, yes. So that was very good.
Would you like to say anything about the staffing?
Yes. So that's really, really helpful. Thank you. I do appreciate everybody's time going out on the 15 steps. We always feed it back on Monday. We'll feed it back to all the heads of nursing and the matrons. As far as the staffing is concerned, we are using, well, there are two issues. Today we have 40 extra beds open. We can actually go up to 50 extra escalation beds, and we have 40 open. So when we have escalation beds open, because obviously everybody will know we've got lots of patients coming in through A&E, and we can talk about that later, we have to accommodate them. So we have to spread our staff a bit like thin butter on toast is the best way of describing it. And what we do is we backfill with agency nurses and temporary staff. And when you use temporary staff, they work very hard, but they do not know the level of information that one's substantive staff would do. The other thing is we've had some retirements at band 7 level, and as it's about leadership of wards, and you know when you walk on a good ward where there's a good ward leader, it's all running smoothly. So we recruited recently 3 new ward managers, and what we've done is we've put them up to an 8A, so we've recruited ward managers at 8A level as opposed to band 7, because we have struggled to get experienced ward leaders into this trust, and we've just appointed 3 excellent ones who are very experienced ward managers, one for C3, one for B6 and one for AMU at Tutor Reed on Epsom site. So it's about ward leadership and ensuring the right staff are in the right place.
Thank you very much. Anybody else who I've missed who went somewhere else this morning? I know you were all very pressed, the execs, so we had a smaller number. No? Okay. In that case, we'll move on to the main agenda. And the first is apologies for absence, which we have from Lawrence, which is why I'm sitting where I am, and from Elizabeth Bishop. That's all, isn't it? Indeed, yes. And we have a new member who has already spoken very effectively, Martin Kirk, we welcome as our new associate non-exec. Martin, would you like to say a little something about your background and
Sure.
introduce yourself?
Sorry. Okay, so I was born and grew up in Dorking, and most of my career was in the private sector. There's a number of major companies working on HR and change and transformation, both in the UK and overseas, particularly in Sweden and the US. And then I worked for on the Olympics, leading the people side with Transport for London, and that led to some work with Number 10 and some other organisations. And currently I'm the Group HR Director for the Post Office.
Thank you very much, and you're very welcome. We look forward to working with you. So, declarations of interest. Any new declarations of interest from members of the board? No? Thank you very much. Minutes of the previous meeting. Let me get these up. Okay. So we'll go through first for accuracy. If you could indicate if you've got a problem with any page. 1, page 2, page 3, trouble is idea. Page 4.
Page 4H should be MRSA rather than MRSI.
Yes, thank you very much.
That's
Page 5, that was page 5, page 6. I think on page 6 there was the clinical director visited the committee. I think it was the clinical director for surgery rather than just any old clinical director. Page 7, page 8, page 9, page 10, page 11. Thank you very much. Nothing on that. So those with those corrections are approved. So we go to the action log. And the first matter was reported to the audit committee. Peter?
Yes, so at the January Audit Committee, I took a paper setting out all of the steps we have in train to ensure we are appropriately protected against cyber security threats, and there was a full discussion there, and we'll be reporting back at every audit committee on a range of indicators to demonstrate ongoing kind of assurance.
Thank you. The second matter, I think, came up in questions last time, didn't it, Charlotte?
Yes, and I picked that up with
Which is about blood observations.
blood pressure observations were being done in the corridor, which Bess kindly raised with us, and I went back to the matron, Claire Gately, and she says there is a room, and she instructed her staff to make sure the patients are having their blood pressures done in a private room, so that's stopped.
Good. Thank you. And learning from never events and serious incidents, Ruth.
Well, I think the proposal is that the annual report, which we normally take through PSQ, is perhaps augmented this year to reflect a more in-depth analysis of the lessons learnt and how they've been shared. I hope that's acceptable to the committee.
That is acceptable to the committee as its chair. Thank you very much. Okay, so we'll go on to the chairman's update. And I mean, I think in the light of what we heard in the 15 steps, the first thing to do is to thank all the staff again for all the efforts they are making under enormous pressure over the past month or so. It is immensely frustrating, I think, for good staff to not be able to work at the level that they would wish to because they are so pressurised, and they have been doing a fantastic job. So I think the whole board would want to thank the staff for their efforts. The second thing is, I think, I don't know if any of you have managed to go into the League of Friends' new tea room, tea bar and shop. I did actually on day one last Monday. And I'd like to thank all the League of Friends staff here and the estates team, Trevor, for having got that up and running. I think it looks great, and I'm sure it will be a great success. We had a very well-attended launch of our Black and Minority Ethnic Staff Network last week, which I was at, Aruna, Daniel, and Kevin. And I think and hope that that's going to be a real driver for positive change for not just our minority ethnic staff, but for all staff and for patients too, because it's immensely important that all staff feel that they have opportunities to progress, that they are valued, and I think that this network is going to be very important in making sure that we do that at this trust. The other thing that's been going on is the CQC. The CQC did a core services inspection in January, and this week have been interviewing a lot of the people sitting around this table for the well-led domain. So we've had our exam questions, and we hope that the CQC heard about the improvements that have been made since their last visit, and that that's reflected in their report, which I think we are due to receive in a couple of months? May, not before May. We'll have to hold our breath till May. Okay. I think that's probably all I need to say at the moment, and I'll pass over to Daniel.
Thank you, Pat. So, things from my weekly messages to staff. So you can't avoid talking about emergency pressures in A&E. So Siobhan McDonough, who's one of the local MPs, came in for a walk around and to say thank you to people at the beginning of January. And she was so impressed by just how hard everybody was working that she made a really generous offer, which was to hold a celebration to say thank you at the Houses of Parliament, which is coming up in a few weeks' time. And she asked for people to say would they'd like to go. And we have 71 staff and their partners who say they'd like to go and have a tour of the House of Commons and have a little celebration with Siobhan. So that was a really positive thing and went down very well. We also launched our Winter Heroes scheme for people to nominate if they thought that someone had done something extraordinary. And we've had over 80 nominations for that, and we're having a big event at the beginning of March, and we've secured a top name facilitator to come and compare the evening, who is Jeremy Vine, because he's had experience of Epsom St Helier recently and has been saying lots of very positive things about the care that we have been offering, so he's agreed to come and give something back, so that will be very good. Not in the weekly message, but you will have seen that the national A&E data for January came out yesterday, and it was the worst it's ever been across the country for type 1 attendance for hospitals. So the national position for hospitals in January was 77%, but we delivered 89%, so that's 12% better than the national average. It's not as good as we normally do, but to give you the context, we saw 1,000 extra majors A&E patients in the month of January. That's like getting an entire extra week's worth of patients in the month. And I think we did remarkably well to get to 89%. If you sort the entire national data by volume, so you say, take the trusts who did the best and then look at how many patients they have, we were the third best performer in the country because we had over 12,000 A&E attendances in the month of January. So it's not as good as we would want it to be, but still relatively we're doing really very well. The CQC visit, yes, Pat's covered, and we've got another one next week after half term, and they might come back and do another core service too. So we haven't said goodbye to them yet. The stroke unit, which we've spoken about earlier, has had a refurb, and the Mayor of Sutton came to inspect and open it, and there's a photo in the weekly message, but that's now the front page of the Sutton Guardian this week, so that's very good news. In terms of estates stuff, there's lots and lots still going on. For those of you who are observant, you will have noticed that there is still lots of work going on B and C block, despite the fact that the contract, one of the big contractors was Carillion. We have sorted all of that out. It has cost us no more money, and we're about a week behind schedule, but no material impact, and work still proceeding. The lift in Ferguson House, that's taken a long, long time. The scaffolding, I mean, the hoardings were coming down. I think it might open next week.
Monday plan.
They will then have disabled access to Ferguson House. The urgent care centre at Epsom has begun to be opened, and I see the workmen are now busy moving the main entrance, so that we'll then have a new entrance to A&E and the main part of the hospital. And I went to one of our new patient groups, the Inflammatory Bowel Disease Patient Forum, and was quite good. It's about 20 people, lots of our clinicians, lots of the patients, having quite a good conversation about how can we help to look after chronic conditions better. There's a report of the CQC survey into young people, and we did really quite well. We had no question where we were below average, and some questions where we were better than average. That's a big improvement from last time. We've also had the maternity survey since we wrote this, and we have the best maternity results in South West London. And I think that'll do.
Yes.
Okay.
Thank you. Thank you very much, Daniel.
Daniel, could I just ask, in terms of the A&E pressures, are we seeing any signs of easing through the first week or so of February?
So sadly not. We thought that we got to the peak at the end of January, and we had a week where we got back to 92%, and then the first part of February has been as intense as January was. And if you look at the numbers of flu patients, they're kind of mirroring our pressure. So when they go up, actually there's a lot more activity. They went down a bit, and they've gone back up again. So there were 3 new patients admitted with flu yesterday. Do you want to comment, Dan?
At risk of eating my sandwiches for later on, I think there's a strong correlation. We've seen some real clusters of arrivals. So we've had some days in December and January, we've seen double the number of patients coming through resus and a significant skewing towards majors. So there's a real issue about our physical capacity to actually see patients at the front door that's slowing us down. That applies on both sides. There were some days where we saw 50% more ambulance arrivals as well than we do on a normal day. So it's more the volatility of what arrives than a sort of steady state that we could plan and predict.
And I suppose the subsequent question from that is, are we able to identify any knock-on implications in terms of the quality of care, anything that's feeding through our never events, those sort of flag criteria that we should be aware of?
We haven't seen cases come through instant reporting. What we have seen in conjunction with actually other trusts, both locally and nationally, is in January, as one might expect, an increase in the number of patients dying, because we very carefully monitor that on a day-by-day basis. And actually, in accordance with good practice, what we're doing to ensure that there is no linkage between that and any operational pressure, is we're doing a deep dive and reviewing each one of those cases in depth. But from our initial analysis, the answer is no. It seems to reflect a complex elderly population and a particularly problematic influenza season.
And I think what we've heard already is the staffing are feeling the pressures because after A&E, they go to the wards, and these are some very sick patients where you would normally ask for more staff, but if you can't get them because they aren't out there, they are really feeling it.
So I think this is probably going to be a theme of the meeting, that the whole system is running hot, and we are, on the edge.
Okay.
Thank you, Richard. Thank you, Daniel. So we'll move on to the IPR, which may give us some more insight into this. Ruth.
I'll start with page 11, which is the mortality page, and to remember this is relating to sort of data from earlier in the year, because it is always presented in arrears. I think it's important to highlight, and this is particularly looking at the September data, that in terms of trust mortality, we had a particularly low mortality in the month of September with an HSMR of 73. The other issue I would like to highlight, it relates to how we split mortality, looking at mortality in patients who were admitted as emergencies, that's non-elective, and patients admitted electively. In September, there were no deaths in patients admitted electively. If one looks at the year-to-date position, you'll see that's amber, and an in-depth review of that has illustrated that we perhaps need to review how we code patients and how we define an elective admission, because actually this does not relate to patients being admitted for elective surgery, but rather patients, for example, complex renal patients or complex cancer patients who are admitted for an elective transfusion or procedure and whose status then deteriorates. So I want to give the board assurance that we are looking at this at patient level on a month-by-month basis. Mortality review, I wanted to highlight that our mortality review process is being further embedded, and I've already alluded to the fact that that process will respond and react to any spikes we see, hence the review which we're undertaking into all patients who died in the organisation in January. I think James is going to pick up some of the domains in 1-2, and then I'm going to pick up at 1-3 again.
So I'll pick up some of the quality measures. I think the trends on this page look quite similar to how they have been over recent months. The proportion of time that patients spend on the stroke ward during their acute admission is below our expected standard, and that's a reflection of the operational challenges that we face in terms of bed availability on the stroke ward and the volume of patients being admitted through our ED. Some level of assurance to the board is that we are very careful to ensure that during the most acute stage of the presentation that patients do get admitted to the stroke ward, and then they're risk assessed if they need to step down onto another ward for parts of their rehabilitation programme. And this is something that we're going to have ongoing monitoring of. I think the most disappointing parameter on this page is our compliance with performing an electronically recorded risk assessment for VTE, so that's people at risk of having a deep vein thrombosis. This data relates to November data. Since the start of December, we've implemented the new electronic whiteboards on the medical wards, and it's being rolled out across the other wards as we speak. This gives much more visibility in real time about patients who have or have not had their risk assessment completed. We've got some embedding to do with the medical teams so that they can follow this through, and I've certainly been trying to remind and educate the medical teams as I've been much more operationally involved through the pressures this month. We've also picked this up through the performance meetings. I was very pleased that the Women's and Children's Division in particular are extremely hungry to get at leadership level real-time data on a day-to-day basis so they can help support individual consultants to follow through. But the biggest challenge relates to embedding this fully within the medicine division.
Just to pick up some key points on the 1-3 page, I think you will note that in December we reported 4 SIs as an organisation, And one of those SIs was actually categorised as a never event. And once that investigation has been completed, it will come back to the public board in accordance with our procedures. The other thing to highlight, again, links into the discussion around operational pressures. Our compliance with completing comprehensive investigations, albeit a small number, in a timely way was obviously exceptionally poor in the month of December. And that represents, I think, is a reflection rather of us struggling to get clinical leaders to complete the investigations in a timely way when their duties on the wards have to become their first priority. So as a leadership team, we are meeting with the division most particularly affected, which is actually medicine, to look at how we can help them ensure that these very important investigations continue to be undertaken in a timely way at a time of operational pressure.
Any questions on those measures? No? They have been fully discussed within PSQ, but nevertheless other members might want to ask. In that case, we'll press on. I think it's you, Charlotte.
So moving on to the bottom of section 1.3, the safety thermometer we didn't do in December because it was a particularly bad day and I cancelled the audit. It's normally an audit that every nurse in charge does on the ward. It was more important to look after the patients on that day. The falls have slightly gone up, but again, this is reflective of the activity we've been doing. We still are benchmarking below the national average. On 1.4, safe staffing, you'll note that care hours per patient day has reduced, and it is because we have extra capacity open, we have extra beds and extra wards open. And we've not been able to get as many healthcare assistants as we would normally have to backfill the registered nurses because through the bank, because they had Christmas and they've also been unwell themselves. What we've done to try and mitigate that is, particularly during December, on four occasions we used our clinical nurse specialists. So there are nurses that are non-ward based. So if a clinical nurse specialist was not doing a nurse clinic and seeing patients, we would put them on the wards and they helped out, and that included our falls nurse and our infection control nurses. So the red flags at the bottom of page 1.4, a red flag is when you only have one registered nurse on a ward. That alerts us to we have to take urgent action and that's when we brought the CNSs in.
And Charlotte, the mix of staff on the wards, I mean, that's also going in the wrong direction,
Yes.
isn't it? Is that, at what point does that become critical, do you think?
So we take each ward on a case by case. So if we look at a ward and it's gone to 50-50, so 50% registered, 50% healthcare assistant, we put the matron down on the ward to do as much as her work and to help on the ward as possible. So you have a greater sort of senior leadership presence on those wards, and we look at that on a daily basis. We do an 8:30 telephone conference and again at 5:30, and we're looking at the staffing there. So we mitigate it as much as possible.
Thank you.
Moving on to infection control on 1.5, we didn't have any bacteremias in December, I'm pleased to say. We have now implemented the ward-based decolonisation programme, which means the nurses can start looking after the patients with the right wash and nasal cream without it being prescribed by a doctor, which is much better. Clostridium difficile was running over trajectory, but actually we've just got January figures and we're one under at the moment, which is good. Hand hygiene, our main problem there is staff weren't able to do as many audits as they previously had done, but that's gone back up again. We have our new infection control lead doctor in, and Dr. J, and that's working very well. And we've also recruited a new infection control head of nursing, who's very experienced, been a nurse consultant at Ashford and St Peters, come to work with us.
Good. Thank you very much. Maternity?
Moving on to maternity, on 2.1, I think the only thing I would draw people's attention to there is the severe postpartum hemorrhage. If we go back to July, that's when we started to implement, I can never say this, carbetocin to reduce the risks of postpartum hemorrhage. And it's really, I think it's excellent to see that we've got a real reduction. Okay, we've come up a little bit red on December, but we've got a number of months now where we've seen a better, a lower rate of postpartum hemorrhage, which we believe is due to that. The caesarean section rate, there's some national work going on that because it is related to ladies that come in with reduced fetal movements are more likely now to go for a caesarean than they were before. And I think that's all I want to say. If there are any questions, happy to take them. Any questions?
Lisa.
Thank you. On the friends and family test, particularly looking at A&E, we've started work with Health Watch and the team to understand how we can better support our patients and hear real-time feedback from them, as opposed to, because at the moment the comments that are coming through that are negative are around waiting and the time that people are waiting to see staff. So we are doing a piece of work which is going to be led by Health Watch, and we aim to complete that by the end of this financial year, so that will give us some really good intelligence going into the new year. You already heard Daniel say on the maternity report that we've had in, the excellent results we've had, and this is mirrored by the Friends and Family Test in maternity. We scored exceptionally high in the National Maternity Service around the birthing element, with the women saying they felt very supportive, they had a good birthing experience, and that was a significant number of women that were surveyed. So that's really great to know, and it's reflected in our information that we're reporting to the board. In terms of our PAL service, our Patient and Liaison Service, Advice and Liaison Service, we see fluctuations month on month, but we are seeing a steady increase and rise in the number of people using the service, and I think that's a really good thing, and I think that's being driven by the fact we now have a service available on the Epsom site that is a manned service. We've managed to recruit to some new posts there, so I think that's having a positive impact to support both patients and visitors and staff, because our staff use that service as well, to support in answering queries and questions. In terms of complaints, we did see a dip in performance in terms of our responses in December, and a lot of that was down to the volume and the activity within the divisions, because they were incredibly busy. However, I'm pleased to be able to report for January that has significantly increased, and some weeks we see 100% in terms of the turnaround on complaints. Measuring the numbers is one thing, but also measuring the output of what complainants are seeing is really, really important, and what we're doing about them. And we've started now to build a number of materials that we are using with staff to help them to understand what complainants see and how we can change and make it better. We are using that as part of our induction, so I deliver that at induction, and we also shared a really good one which was specifically given by a junior doctor to our junior doctors as they entered our organisation for the first time this week. So we are using live information for the first time.
That's very good to hear. Thank you, Lisa. Dan.
So moving on to Operations Cancer First. This report's a month in arrears, so for November 2017. So we're back to achieving the standard across all domains, which is really encouraging. And we've now got the figures for December, and we're pleased to report that the trend for that will continue into December as well. So an encouraging position on cancer. The work that's ongoing at the moment is about nailing down the 2-week wait standard and trying to see people where possible within a week rather than 2 weeks, which is well ahead of the national standard. Moving on to elective care pathways, it's probably worth stating at this point that early in December we were given some joint direction by NHS England and NHS Improvement about focusing very much on non-elective activity and in some cases cancelling our elective activity. that has accounted for a good amount of the change in the RTT performance figures across September. And where people may have worked ad hoc sessions to stay on top of RTT, they have instead volunteered to be working on the wards in ED and keeping our patient flow going. And we've seen that reflected now in the numbers of the change in the backlog for RTT, which has gone up by about 300.
Presumably you meant December, not September.
Sorry, December, yes, sorry. However, some of the progress is still being continued, and we can see gentle reductions in places like T&O and gynecology, which have had long-term high backlogs, and even they have still been able to reduce them a bit in December. Our diagnostics were an issue in December. We missed the standard by 0.02%. We know where the issues were, and again, for January, we're likely to exceed the standard significantly, and that position will continue into February. Elective length of stay has gone up, but I don't think materially, and I think that will fall into normal variation. And I think that change will reflect the fact we're seeing the patients we have seen electively have been the sicker patients who therefore potentially needed to stay longer. And we'll just monitor that position closely, but I think that's the most likely cause of it. The final position is there have been 3 breaches of the 28-day standard for cancelled operations. Again, I think that reflects the operational pressure we've been under. And in some cases, we have told patients that it's not been possible to bring them in advance. In some cases where the position the day before, with their agreement, we've said, we don't think this is going to happen, but if you're willing to wear the risk, please come in, and if we can squeeze you in, we will. And the cancellation numbers going up has been a reflection of that. But in many cases, we've actually got the patient's operations done. So this 3 number is a reflection of us just trying to push it slightly and keep bringing people in, which is good news for those we've been able to continue seeing. If I move through to non-elective care pathways, as Daniel has already alluded to, December was an exceptionally challenging month. And although our overall volumes compared to December last year were broadly the same, what is significant is a 7 to 8% rise in the number of cases coming through our majors and resus streams. And broadly, that change has meant that we've been seeing 1 extra majors patient for every majors space in each of our EDs. And that clearly takes up an additional amount of time. We've done a significant amount of breach analysis, matching them to our staffing positions. And we know that we've got our staffing planning matched to when our demand is coming in. So we think it is front door pressures. In terms of non-elective length of stay, a small but we don't think significant change in December. Delayed transfers of care still within normal tolerance, but it's the ambulance position that has changed. And again, we've seen a higher volume of ambulance attendances compared to the same position for last year. And that has been reflected in the number of ambulance handover delays. Those have gone up across the system, and there's been a significant amount of work, both with us and London Ambulance and CCAM, over the last 6 to 8 weeks, and we know that the position for January and February will be significantly improved in terms of delayed ambulance handover times.
Going back to the letter that we got from NHSI, what exactly was put into place when that letter was received about cancelling operations?
What we did was to first of all examine our elective activities. So it's not just operations, but it's things like outpatient appointments. So the first thing we did was say, what do we need to have on the ward? So we thickened up the cover of our medical teams on the wards every day, but also said it's not just a question of having a ward round in your job plan, perhaps at 11 or 12 o'clock. We need those things to happen at 8:30 in the morning. We need you to be on the wards, on the MDTs. So that has meant we often had to take out outpatient clinics to ensure that the consultants were then available first thing in the morning. And James alluded to the fact there's been a much greater presence medically on the wards throughout the period of December and January as a consequence. We think the rise in our backlog, or the early analysis, suggests that it's about 2/3 outpatient appointments and about 1/3 operations. Some of those have been as a result of using escalation capacity for medical patients, so we've not been able to fit people in. And there's been a daily prioritisation of the most important cases and making sure those come in, so particularly our cancers and our trauma cases and the most urgent clinical cases.
Thank you. Any questions for Dan on that? Thank you very much. Kevin?
So 3.1 on the performance report. The first page is mainly around staffing levels. You can see the downward trajectory on vacancies and there's continuing increase in our substantive staff, particularly in the clinical staffing. highest area of vacancies is estate and facilities, and Trevor's got a plan around that. We've also been growing our allied health professionals, and we've had some successes around sonographers and some niche, almost areas that have been difficult to recruit in the past, so that's positive. But as Charlotte mentioned, because we've got extra capacity open, it doesn't feel like we're growing the workforce to the staff because it's just stretched across the trust. So it still feels, pretty pressured out there, even though the numbers are going slightly in the right direction. And obviously we're maintaining the focus, as you can see, on the nursing recruitment, the medical recruitment. We've got a big focus on at the moment, which we'll touch on later on in the meeting, I think. And then at the bottom part there, you've got our performance against the agency expenditure trajectories and caps. The slightly under trajectory, which is positive, but the main area continues to be medical staffing, which is a problem for all of London because it's a seller's market. London HR directors have agreed a London cap to try and manage that market, and we are seeking to get within that London cap. It is a struggle, but we're putting the effort into that. Moving over to the second page, again, the top there, you can see the nursing net changes, which are still positive. Absence is another reason why it's going to feel worse out there for the staff. The figures you can see there are basically we're tracking the same trajectory as last year, but I have the January figures, which are 5.5%, which is probably the highest absence level we've had probably 18 months, 2 years. And so that also has meant January has been particularly problematic and obviously has a financial impact as well because of the agency that would need to cover that. The turnover, a big focus here on the management development that we've talked about, to try and improve the staff experience as well as improve the staffing levels, because that's what drives really the turnover, apart from the career development that we can't necessarily resolve, but trying to support staff develop careers and training. And then finally, 2 areas that have suffered from the capacity challenges as well, but slightly different approaches with these two. Statutory manager training, we had a big push on statutory manager training in what we call the Autumn 4, which was statutory manager training, the flu jab, doing your mid-year review, and completing the staff survey. It hasn't had that impact on statutory manager training. Obviously, we're trying to do that at a time where the trust is under quite a bit of pressure. We've seen that staff that have been booked into training then have to be kept on the wards because of the staffing level. So we've taken the decision at exec level that we should push the compliance sort of promotion for statutory manager training into Q2 of the year, which will be obviously July, August, September, which is going to be as quiet as any month, even though obviously no month seems to be quiet these days. So that's a decision to try and help get compliance better with that. When we look at our compliance with other London trusts, we're still up there at the top, but obviously that level of compliance is not good enough still. And then finally, mid-year reviews. This is an area of disappointment. Obviously, the capacity problems have an impact on the clinical areas, but there's no real reason why the people in the non-clinical areas should not be doing mid-year reviews. We feel there's a problem here about managers really realising the benefit of doing those mid-year reviews. Obviously, we're doing the management development, which is reinforcing the need to have regular reviews with your staff. Managing compliance through performance management can be counterproductive because you just turn it into a tick box exercise. So we're trying to just get managers to feel the value and use this as good practice through the management development in the non-clinical areas, and trying to work on spans of control and support in the clinical areas where you might have a ward manager trying to do too many mid-year reviews. So that's the approach we're taking there.
Thank you, Kevin. That is very disappointing, actually, the mid-year reviews, because, I mean, it's an opportunity both to feedback good things and to encourage, changes before you get your end-of-year review, and no surprises when you do. So I think we'll need to keep a very close eye on that, because if it doesn't pick up, the end-of-year reviews are going to be much less effective.
Yeah, I mean, we're coming into the period now where we're starting to promote the end-of-year reviews. And again, we need to make sure, particularly in the non-clinical areas, that people are doing those end-of-year reviews.
Are staff encouraged to ask for their reviews?
Yeah, I mean, Daniel pushes it a lot, and it's something that Daniel personally will push with the teams, and in his weekly message say that you should be asking for your reviews, and we also pick it up at the performance meetings that we have with the divisions. I think that the culture is that, I don't think this is particularly interesting when we start working with Martin more about this in other sectors and industries, but there's still this feeling that any type of review is something that's not going to be a good experience, and that's what we need to get over. I think that the staff, even we've had staff within the executive team where they're performing really well, but there's a culture and a thinking that it's going to be a negative experience, and that's what we need to try and get across, that this is and Daniel, as I say, from the top has reinforced that this should be a two-way, a positive thing. But I think traditionally this is always seen as something that you should be afraid of because you might get told off, which is really one of the barriers, I think.
Thank you. Communications and engagement?
Thank you. The only place in the world where I think it's quieter in December is the media. So you see less media inquiries typically in December. What I'm really pleased to be able to report, though, is we focused a lot of attention on our social media, and we got a lot of pickup about, particularly about in December, about our tweets around where to go other than A&E. So it might not have felt like it from A&E's perspective, but we did get a lot of pickup in sending those messages out. And also a real strong one for us in December was advice for local party goers about sensible drinking and about looking after yourself. And the really lovely one that we did around and got a lot of focus on was our Christmas memory tree. And a lot of people took part in that. So whilst it was quieter in terms of the media front, we took the opportunity to use the social media to get some really key messages out and support our partners, health partners across the patch, really. So we supported them in doing that.
Thank you, Lisa. Rakesh?
Thank you, Pat. So on financial performance, the first financial performance target, income and expenditure, board will notice that I've now split that into two targets. One, the top one, where our target is to achieve £28.2 million deficit before we receive our sustainability and transformation funding of £10.3 million. And board will recognise that the STF funding is predicated on us achieving our financial target and also our A&E target. So before STF funding, at the end of Q3, the first 9 months of the financial year, we were ahead of our plan, so marginally ahead of our plan by £200,000. However, if we take into account the STF funding that we were planning to receive in the first 9 months, we're now behind plan because in quarters 2 and 3 we didn't achieve our A&E targets despite us being comparatively better than other trusts. We didn't achieve the targets we were set, so we didn't achieve quarters 2 and 3 for A&E, and therefore we didn't receive £1.4 million of our STF funding. So looking ahead for the remaining 3 months of the financial year to hit our target before STF, it looks very, very tight. We've talked about the cost inflation associated with additional pressure. We've also lost revenue because of our elective cancellations we had in January as well. So it looks really, really tight, and I'm working closely with the divisional team, Dan's team, and the finance team to see where we land at the end of the financial year. When we take the STF funding into consideration, I think we will miss that target, because once you've missed STF funding, you cannot get it back. So that's the INE, the two metrics for our income and expenditure. Income and expenditure is also a function of how well we deliver our cost improvement program, and for this financial we had a cost improvement program of £15 million. despite the busy period we've had in December and continue to have in January, we did deliver a significant amount in December, but we are still behind plan year to date and forecast to be so as well, and that obviously contributes to us the pressure we feel in delivering the year-end I&E target. Against capital expenditure, we've reported here the significant capital program we have for this year, and we're forecasting to spend £28.8 million, just under £29 million in this financial year. So we're behind plan at the moment, but Trevor's team is working, and we forecast we will get to that point. The good news is we've now received official confirmation that the Department of Health loan of 25.1 million has now been confirmed, and we've received the first tranche of that of £5.2 million this month. And that will obviously help us. That is a central plank to our £91 million capital investment programme over the next 3 years. And so the capital programme for this year, augmented by the £5 million we've got this year, will support that. Cash. So currently in the bank we have £10.8 million of cash in the bank. A big chunk of that is ring-fenced for blocks B and C, and if you take that to one side, we are holding £2.1 million of the cash, and the Department of Health limit is for us to hold £2 million worth of cash. So we're on target for that, as well as we draw through year end. And lastly, our commitment to paying our creditors on time, and that again we're at 93% and significantly better than the trusts around us.
Thank you, Rakesh. Any questions for Rakesh on finance? Okay, thank you very much. So, Peter, we'll move on to the risk register.
Thank you, Pat. So, the risk register, there's 3 points I want to make. The first one is overall, the risk register shows no significant changes from the previous month, apart from one risk that we've removed from the risk register because this was to do with our telepath servers, which were on an old platform that has been on our risk register for some considerable time, but now that has eventually been able to be removed because all the work has been done to transition to a new server. So that's the material change, is that risk being removed. Given the pressure that the organisation is under, I think it's worth repeating something that we alluded to in the January public briefing, is that there were 2 material new risks that we added the previous month. One was an escalation of the risk about our capacity to do everything that we is expected of us and by our patients and our regulators and the public around our ability to deliver anything. The language we used with the CQC on early in the week was that we feel that we are kind of at but not beyond our limit to manage all the things that are required of us. So that risk was added. The other element that we added in January, which might have been missed, was around the new risk around the ED department and delivering the A&E standard presently. So those are ones that were added in January, but I think it's worth reflecting in the public board that those are still there. At Park, we reviewed all of that in considerable detail and were satisfied that actually, despite the further mitigations that and the reviews that we've done, that those remain the case, that we're not yet able to de-escalate them, although there are further discussions about how we can increase our capacity to manage all the things that any NHS organisation is expected to deliver. So those were the material changes that I wanted to flag up that have come over the last 2 months.
Thank you. I think would it be worth mentioning that the top team looked at our objectives and to see whether we could thin them out at all to help with the capacity issue?
Yes. So we reviewed, which we'll come on to in the next item. So not only did we review our performance against all of our corporate priorities, but we then sort of said, well, which one of these can we make a lower priority to create some capacity to manage all of those things. And our conclusion was there may be one or two areas where we can perhaps narrow the focus of the exec team on them. So, for example, some of the work that Kevin's been doing about medical education and bringing some of those things together is to say, well, Kevin will focus on that and rely less on colleagues to do that in a shared way. But our conclusion was there isn't anything on the list that we can actually stop doing because they're all really important, which is why they were on the list at the beginning of the year. But in part, what we have sort of said, some of our mitigations, both at a board level, is with Martin's arrival as the new associate non-executive director, that will create greater capacity at board level about getting insight and assurance around the work we are doing, and there's further discussion about exec portfolios. But I think the important element to reflect why we're still saying this is at a 25, the risk isn't just about the senior leadership around the board table, but actually throughout the organisation. So the people managing, whether it's operational performance or juggling the workforce on the day or looking at money, it's the same leadership team in divisions who have to juggle all of those things too. So it's a reflection of how hot the whole organisation is running, not just in either in pockets or just around the board table.
Thank you, Peter. Okay, we'll move on to the board committee reports that are associated with what we've just heard. And the first one is from my committee, the Patient Safety and Quality Committee, which last met on the 26th of January. There is a summary report in the papers. The most significant element of that meeting was we had a presentation from the clinical lead for maternity, during which we heard about the work that's been going on to try and reduce the postpartum hemorrhage rate, and with good results, I think, which will come through slightly slower time than we've already had, but certainly it all sounded very promising, and also that the caesarean section rate is looked at very closely by a joint medical nursing leadership team. So that was good to hear. We obviously heard about all the elements that are relevant on the performance report that we've just been reviewing. So a number of those items, particularly to do with the stroke service and VTE, we went into in considerable detail in discussion and are looking to see some improvement. We also heard about the next phase of Patient First, and I think there is an issue for us to make sure that we involve the patient voice more generally, not just through Patient First, but through committees, and Daniel's attendance at one of the patient groups that does exist is a useful example of what we would like to see more of. We had assurance on inspection on emergency preparedness, which we'd asked for from the previous meeting, and we looked at the corporate priorities that Peter has been talking about to see those that were relevant to the committee, whether we were satisfied that they were properly articulated and rated. So that's from PSQ. If I can
just give you one little update?
Yes.
So on stroke, so there's this quarterly assessment about how well you're doing, and we were at E, which was the bottom. But the one that's just come in this week, we're at C. So there are good improvements going on in stroke.
That's very good to hear.
Right, so most of what we've covered in Park's been discussed already this morning. Significant discussions around the tension and the reciprocal relationship between planned care and emergency care, and referral to treatment was clearly one of the major challenges discussed in association with the increased flow through the emergency department, and noted that the cancer access targets were still maintained and risk was mitigated as much as possible. We've talked about the risks around the senior leadership team and the capacity issues that they're facing. And we've commented on the risks that have left the register. So most of it covered by Peter.
Thank you very much. So, Richard, the Finance Committee. Oh, is Rakesh going to do?
So the paper in the agenda covers two finance committees, one held on the 30th of November and one held on the 4th of January. In the earlier meeting, we talked about the month 7 position, which obviously has now been superseded by the December numbers. Trevor gave us an update on the capital program, and we approved an investment into infrastructure for energy as well that Trevor is now proceeding with. For the 4th of January Finance Committee, again, I gave an update, and we went through in some detail on the month in November's finance report. And again, that's been superseded by December's numbers we've discussed here. And we talked about cleaning and portering services and the Sutton land sale disposal and awarding a contract for surgically ambulatory care as well. And again, Trevor gave us a comprehensive report on the progress of the capital program as well. And we discussed additional A&E monies that the NHS, the Department of Health, has made available to all trusts.
Sorry, the only thing I would add is that we spent a lot of time examining the likely outcome for the current financial year and the risk around achieving the control total, and that all forms an important basis for the budgeting for next year as well.
So Daniel, the Trust Executive Committee.
Well, as you can imagine, we spent most of the last 2 meetings talking about how do we actually deliver everything. And then the slightly amusing part of the 20th of December tech was planning for the CQC visit whilst the CQC decided to come and observe how we were doing the meeting, which was quite complicated to make sure that we had a good conversation at the same time as not causing ourselves unintended consequences. But I think we managed it.
And finally, POD, People and Organisational Development Committee, which Aruna now chairs.
Yes. So yeah, it was the first one that I chaired, and I guess that the focus really was threefold. We looked at corporate objectives and how we complied with it, and also the well-led piece of it. And I think the thing that really came out from both of that was our compliance with RES, and I think that that is something that we're going to keep an eye on going forward and keep that on the agenda. Workforce and Race Equality Scheme, yes. And that takes me on to one of the topics we spent quite a lot of time on, which was about the BME and the equality agenda. And that we had our meeting just prior to the launch of the BME. We did have some action plans, and we're going to monitor those going forward. And our equalities and diversity lead manager, Shabir Abdul, is now going to be a member of POD going forward. So I think that a lot of focus on that going forward. The other thing that we spent a bit of time on was the initial results from staff survey. These were disappointing. Particularly on the take-up, which was lower than last time. We do need to do a little bit more analysis in terms of the responses and where they're coming from and who actually participated and what the actual issues are. So again, a lot of focus on that going forward when we have a more detailed breakdown of those results. So I think, yeah, that's it.
Thank you very much. Thank you, Aruna. Okay, any final questions from anybody around the table on or any of that material?
Sorry, Chair. The audit committee report is under governance. Is it worthwhile taking it under here, or?
Well, since Elizabeth isn't here,
yeah.
Perhaps should do that. Thank you.
Yeah. So the audit committee was held on the 9th of February, which Elizabeth Bishop chairs. And the standing items that were discussed at the audit committee were our losses and compensation report, salaries overpayment, and single tender report. We also discussed in some detail the year-end accounts preparation timetable, which we have agreed in conjunction with our external auditors, KPMG, and they also presented a report. Internal audit presented 2 internal audit reviews they had undertaken over the past quarter. One was on Swelliok for which we received reasonable assurance, which is the second highest level of assurance, and another report on financial management, where we received significant assurance, which is the highest level of assurance. And we had a very detailed discussion, which was a continuation of discussions from previous audit committee on a pharmacy fire that happened last year and the implications and lessons learned from that on a number of aspects.
Thank you very much. Thank you. Right, so we're now moving on to governance and the Guardian of Safe Working. Are you going to come forward, Sandy, and where yes. So Sandy is our independent guardian of safe working practice for junior doctors, and this is your second or third report?
Well, third.
Third report. Thank you very much.
Well, you've all got the report to read, so I thought I'd give you some background to it, because without the background, the report probably doesn't make a lot of sense to you. Basically, the 2016 contract totally changed the way junior doctors work. They now have a work schedule that determines what they should be doing, and they can raise an exception report against that work schedule to say that they've done too many hours or they've missed educational opportunities. The Guardian of Safe Working's job, along with the Director of Medical Education, is to police this and look for patterns and report to the board, either as this report or urgently if there's something going on. So, on the background of that's what the new job plan's about, we've got 360 trainees on the books, but only about 320 at the moment in place. Why is that? There's a national doctor shortage, surprise, surprise. And the way the doctors are delivered to us to train is by Health Education England, and they also have a process ongoing at the moment where they're looking to put doctors, rather than into the metropolitan areas, to the more countryside areas, so that those hospitals aren't seen to be left by cherry picking of the metropolitan centres. Health Education England also supply the salaries for the foundation year people completely, and half the salaries of all the other trainee doctors, along with an educational amount as well. And I did a sort of back of a packet calculation this morning, and I think that we probably, Rakesh will tell me exactly how much it is, but it's of the order of £10 million comes to the trust courtesy of these trainee doctors. Okay, so HEE worry about the trainee doctors, and they come and inspect. And we had an inspection at the end of last year where they issued 3 what are called immediately mandatory responses, which we had to answer. The detail of that is in the medical director's report. That's going to be reviewed in March this year. And if the trainees are removed from training, it will dramatically affect the trust's ability to do what it needs to do. And there'll also be a serious financial implication, because to replace those doctors with non-trainees, all the financial burden will fall on us. So that's a background. It's not very nice, I'm sorry. Junior Doctors Forum, we now have one in place, so the junior doctors have elected a committee, and they are the voice of the junior doctors. And recently I saw that Ruth had a fantastic email from one of the junior doctors. The voice of them, they're now willing to speak to anybody rather than sitting there silent. Okay, exception reports, that's what I'm here for. The majority come in medicine. The majority come from the foundation year doctors. Why is that? Well, it's because they really are the front line on the medical wards. On surgical wards, there's surgery going on other wards there's other things, but the front line is the doctors are seeing the patients all the time. Unfortunately, the gaps in the rota, which were brilliantly tweeted in a very bad way by our Secretary of State for Health, who posted a rota and said, look, we're doing a really good job. Most of that rota was red. It was a dreadfully unsafe rota that he posted. So he doesn't understand either. So to get back to where I was, the majority of the reports are coming from junior doctors who are just doing too many hours. And the reason they're doing too many hours is the level directly above them, the SHOs, are the area where the main rota gaps are. So their level of support is reduced. It was fascinating that Dan mentioned something I'd completely forgotten earlier on. I couldn't work out why the level of reporting in November, December, January was lower when they were busier. I thought it can't be just that they're too busy to report, because they can report in 10 seconds on the app. And actually, it's probably because of the presence of the consultants early in the day that the consultants actually know what's going on. And maybe this is an area for the board to think about and look at changing practice within the hospital. Moving on. The immediate safety concerns, the doctors are allowed to flag up anything that they think is an immediate safety concern. An immediate safety concern is usually that they feel that the situation on the ward is getting unsafe. So it's very similar to the nurse. Once you're down to one trained nurse on the ward, things are bad. The immediate safety concern, and any of those I report to the clinical directors involved and to the medical directors. Three in particular came up a lot during the end of last year. There's a thing called the 416 page or bleep, which you will read about. This is a historic device that back in the day probably worked very well, but now during my talk it would have gone off on about 20 occasions already. This pager just goes off continuously between the hours of 5 and 8 when the hospital at night team come on. This has been addressed because it was one of the immediate mandatory responses. Care of the elderly, especially the hip fracture unit, a lot of reporting there, but that's understandable because it's an open-ended service. There are 20-something beds in the hip fracture unit, but if we've got 40 hip fracture patients, that same group is looking after the 40 hip fracture patients. There's an area of practice to think about there. Responding to the exception reports, I have to say that I've been very impressed by the executive's efforts to look at medical manpower, to look at medical staffing, to look at different ways of working. The unfortunate thing is that the idea that always comes up is, let's employ senior nurses to do this. But as we know, the senior nurses are in very short supply and already doing senior nursing jobs. So I'm not quite sure where that's going to go. The one sort of thing that I'd like to say at the end of all of this is that I still have concerns that when I read the text of the exception reports, that the most junior doctors, although less so in the last 2 months from what I just said, they have to fill in a little text box that says, what have you done to resolve this at a local level? And too often the resolution at a local level is contacting medical staffing rather than the medical team that's around them. And I just wonder, well, I'm stating that I think it's very important that the Trust pushes towards the trainee doctors and their consultants taking ownership of the rotas they work on, because they're the people who are actually doing the work. Somebody in an office at East Street does not understand what it's like at the coalface when somebody doesn't turn up. Thank you.
Thank you very much indeed. Would James or Ruth like to respond on just that point? Because clearly the relationship within the team for a junior doctor is going to be very important.
So firstly, I'd like to thank Sandy for his comprehensive report and to acknowledge that you've gone way over and above your job plan, so you would put your own exception report in on the working hours. And I know the junior doctors really do appreciate and trust your independence from the management structure, and they feel that they can have an honest dialogue with you, and that you will advocate strongly, and you absolutely do. And it's also very helpful that you come to some of the medical workforce meetings where together we try to find solutions for what are very knotty problems. Underpinning these challenges are clearly the gaps in the medical rotas that we have. And I absolutely do endorse the underlying theme that you're raising about both the trainee doctors and the consultants, particularly in the medicine division, need to work together to own the problem individually and collectively to find solutions on the ground, because they are the people that hold the solutions, whilst as an executive team we're clearly here to support them and fundamentally to try our best to improve recruitment and short-term staffing where we have gaps.
Probably a couple of other updates on that. As Sandy's mentioning, the support within the division. I think Sandy mentioned East Street, and we did centralise the rostering. But one of the decisions that the Trust Executive Committee made in the budget setting for 18-19 is to support some divisionally based medical staffing posts, because I think that's where on the ground they also need support to make sure that that's happening. So we closed the advert last week, and we're interviewing next week, and we've got some good candidates for 3 medical staffing posts that will sit in medicine, surgery and women's and children's as the biggest divisions that have the biggest challenges. And also in medicine, one of the doctors has really taken a lead, and it's really important that that link is happening, and Nithi, a doctor at Epsom, is doing that, so that's improved. I think the data on the annual leave as well, I think that's from November, is it? And so with that, we've spotted that in November, and I've got the data for December and January, and without reading through every line, significantly improved. We've put in a maximum 2-week deadline in terms of getting back to people about annual leave requests, and paediatrics has massively improved. If I look at November, 20 and 22 were over that target. For January, the figure is 4 and 1. So we significantly reduced that problem, but as Sandy said, we're still working on this divisional support, which is part of the solution here.
I wonder if I could ask Sandy to perhaps give us a context on how he sees us fitting in the regional and national pattern, because you do go to network meetings of other guardians of safe working.
It's very, very interesting. There's quite large differences even within the South London setup of the number of reports. Some trusts are up well over the 2,000 number of reports. We're at 372 as of yesterday. Some trusts have got 20. The concern of the CQC and, oh, by the way, the CQC, they bombed our meeting as well. The first meeting we had of our elected junior doctors committee, the CQC were there as well. The junior doctors, I didn't even tell them who it was. I just let them talk freely. Anyway, I digress. Nationally, the CQC and the GMC are really concerned about the low reporters and the high reporters. And we're in the sort of lower third of people, but we've got good responses to the things that we've done. I'd be very concerned if I'd only received 20 exception reports in a hospital that's this busy and has these rota gaps. It would point to me that there is a big problem. The chance of there being a major headline about exception reporting is quite high at Guy's and St Thomas's. I won't say more, but watch this space.
Sorry. Just a couple of points on the report, and I understand the context, and I'm glad that we're not sort of an outlier, but just a couple of points that I picked up. It says that in most other trusts, the DME is part of the board. Is that something you would suggest we do?
I was sitting here today listening to what, as you went round the table, thinking, I wish John was here because he could make very positive comment. John Clark is a microbiologist who's just about to cease being our Director of Medical Education. And he is actually the guy who runs this centre and is in charge of that £10 million. And I can't think of any other director that's got a £10 million at least account in his hands that isn't sitting here at the moment.
Okay, so I mean, if not here, minimally at POD, we ought to have.
It's a complex system, I know, Daniel.
Can we take that away?
So I think him coming to POD is a good idea. But there are lots and lots of people you could have around the board table who have really discrete responsibilities. And I would not advocate that we had that he came to this meeting. But we are quite unique in having 2 medical directors, and I think James and Ruth are able to communicate to us the issues relating to the medical workforce very ably to this forum.
The suggestion that he might come to POD is perhaps one, certainly as a sort of invited informal to give a viewpoint on one occasion and see whether it would fit with his no doubt very busy schedule. Yours doesn't work either.
Yeah, so I think one of the initiatives that we've had in 17-18 is to raise the profile of education in the Trust as a university hospital, so I think that would fit with that strategy as well.
I agree, and I think that the DME report is incorporated into Sandy's report, but actually having that report presented discreetly might be a helpful adjunct to discussions we have here at the board.
So, may I ask one more? It also said somewhere in the report that for the stuff that the HEE brought up, that we were aware of 2 of the IMRs. Do you have a view of why? And we solved them within the 5 days. I guess the question that raises is, why didn't we solve it ourselves when we knew about it? Do you have any insight on that?
I think that there were efforts going on to try and solve it in advance of HEE arriving, but HEE arriving, they hold the ace hand in that they can say, sort this now, or you've lose your trainees, as happened at West Middlesex. Mm-hmm. They had all their trainees taken away and overnight became a non-critical care hospital.
And sorry, may I ask one more? Could you give us, there's a phrase you've used here, could you give us some insight on that, which was troublemakers who should be kept quiet?
The insight and background to that is that we have a load of junior doctors who are millennials, and we have a load of consultants who, like me, are definitely not millennials. And in our day, we did not report like this. There was a feeling at the start of all of the reporting that this was just people making complaints because they could. And actually, it's not a complaint. It's a statement that I have worked extra time, and I either want time back for it, I want money back for it, or I want you to address the problem that my work schedule is not applicable to me. If I have to be there at 8 in the morning, but there was a sort of background hum from the seniors. Why are they doing this? There wasn't that realisation that actually it's a contractual requirement.
And we're not alone in this. This is every hospital because of the change in the working.
Yeah. As I said, the hospital has 20 exception reports. You can guarantee that that is the attitude. And if you want a good reference from me, you will not exception report.
It's worth noting as well, in terms of looking at that data, that August 2017 was when the final rotas came on, because that's a big rotation, and so there was significantly more doctors on the contract by then, and we were sort of expecting that would become, and we need, like Sandy says, to see where these exceptions are happening. So it's a positive thing.
Yeah. I think just to give, this is I don't know if mine's working either, an anecdotal experience. So I'm an educational supervisor. I have trainees. My trainees have issued exception reports. Actually, as a consequence of those exception reports and subsequent dialogues with the trainees, we've actually made very positive and constructive changes to the rota that I don't think otherwise actually would have been flagged up. So I think we're seeing a kind of culture change, and the system has been used to facilitate dialogue and change that historically has taken a lot longer to arrive at.
Can I just ask about the Junior Doctors Forum? You said they've just elected their chair and so.
So they have a chair, a treasurer, because I am allowed to issue fines if exception reports mount up and one doctor ends up exceeding the working time directive, which is actually in words in the 2016 contract. It's not referred to as the EWTD, it's just there in words. Okay. So I can issue a fine which is 4 times the locum rate.
And is there a good attendance at those
yes.
meetings? And I mean, that's
surprisingly.
Really engaging them. And is there a sort of fall off when you get new? I mean, we've got new doctors coming in at the moment, haven't we? Yeah. I mean, what are they actively making sure that the new doctors? Because what we want to do is to foster a culture of dialogue and so forth.
There's the background hum in the doctor's mess, which is one of the issues that was brought up, but I'll leave that to Trevor to talk about. But there's also Vanessa Carr's work of strategic change in the way the trust works at a medical level, and she's always pushing the doctors to attend the Junior Doctors Forum.
I just want to ask Sandy if you could comment on the other function of the Junior Doctors Forum, which is not just a unionised approach to the contract, but have you managed to see any evidence of engagement with junior doctors in becoming more involved in the wider running and oversight of the trust, and support for some of these important committees that we're very keen for junior doctors to participate in?
At every forum we sell, join a committee, so you're pushing against an open door. The trouble is the doctors have been and are very busy, but I was fascinated to, at a meeting a couple of weeks ago, meet the treasurer of our Junior Doctors Forum, and he'd been presenting as an FY1 at a meeting of radiologists. You don't start radiology until, I think, CT1. So he was 2 years ahead of his time presenting, and he's very involved and has now, I think, is going to become a BMA rep.
Any other questions?
There's a part of your report, Sandy, where you talk about how complicated it is for our trust, given the two-site nature of it. I just wondered whether you could say more about the implications for doctor training of the way we're currently organised.
Okay, so if we were being benchmarked against a trust with whatever number of beds we've got and the number of trainees we've got, most people would think, God, they're doing very well. But unfortunately, on 2 acute sites, we're trying to run mirror rotas. And if you've got a big gap in the medical rota at the SHO level, you really are putting yourself at high risk of not having enough doctors. And I suspect that our spend on urgent locums is directly related to the fact that we're trying to do mirror services on 2 sites. If we had a very big, shiny new hospital just here, it would be great, but I can't see that happening.
That's another discussion. Thank you very much indeed, Sandy, and we do appreciate your frankness on these matters, because it gives us a proper insight into what all the figures are telling us, but that's telling us what the doctors are feeling, so thank you.
Next time I'm going to try and get a trainee to come and do the presentation.
Right. Okay, thank you very much. We're on 4.2, corporate priorities. Peter.
So thank you, Pat. So this report summarises our progress against the 25 corporate priorities that we set ourselves at the beginning of the financial year. The first table summarises where we are. I'm not going to dwell on that, but to take you to the next 2 tables, which are more meaningful. So the process we've been through is both at executive level and then at the board subcommittees, which you mentioned in your, for example, at PSQ. There was a rigorous discussion about what progress have we made, and therefore how does that translate into the colour codes. So this isn't just a guess the colour question. Behind each of these priorities there is a detailed work schedule of the things that we said that we would try to do to make the progress, to demonstrate that we're doing that. So for example, at PSQ, the caring priority number 13 was about how we investigate complaints and do that. The debate was, have we made sufficient progress? The reason why it's gone green is that we've made the progress we said that we would do at the start of the year. That's not the same as saying there's further progress we'd still like to make, which no doubt will reflect into subsequent priorities, but that's how we made that judgment. So I think that gives some illustration there. So the three of our priorities have improved since the previous quarter, so that's around how we manage the acutely ill patient, and that had improved because of not just having a new policy, but the way in which that's being managed, touching on some things that Sandy alluded to around management of the 416 bleep and the hospital at night. The staffing levels and changing roles has gone from red to amber red. The reason being we made some progress around that. Again, Sandy alluded to that in his report. So that's clearly, we're clearly signalling there some progress has been made, but that still means that it's significant risk of not delivering all the things that we'd want to do. The next table summarises those where we've seen a decline in our rating. These reflect very much the things that you've heard about already in the integrated performance report and are reflected in our risk register. The first one is about A&E. why that's amber red rather than red is that it's how far away we are from delivering that, is so that we're below the target, but it's still within reach for the year end. RTT is red because we've clearly under-delivered against the trajectory and the standard. And you can see the other ones. I'm not going to draw out too much from that. The other element, which I think this tool is not just about how well have we done, but is also looking to the year end. So the final table summarises where we forecast we will end against those priorities. And the one to highlight this, the one that's red is the RTT priority, because our collective view is that we won't hit that standard by the time we get to Q4. The amber red ones include the staffing risk, the A&E risk, and our financial position, which reflects the position that we heard about from Rakesh. So that summarises both the progress made and our view of where we'll come out at the year end, which, if you were to translate that into headline percentages, we're forecasting that we'll deliver about 80% of the things that we'd said we would do in the green or amber green perspective, which is pretty much where we kind of landed last year, bearing in mind all of these priorities are meant to be stretching and demanding yet achievable. So that's probably a fair reflection of where we are. I'm sure if colleagues have questions about any of the specific 25, the summary is in the subsequent table, or colleagues would be happy to talk to that. But that's where we are.
Thank you very much. We've seen these in the committee, so most of us have had an opportunity to ask. But are there any questions that arise from this with fresh eyes on this occasion? No? Okay, thank you. We've had the update report from the audit committee. So contracts awarded over 50,000. Rakesh.
Thank you. So the schedule shows contracts awarded over 50,000 in October. All of them followed our processes and were procured through a framework or a tender process, all except one for the cleaning at East Street for £50,000. But and we have a plan for that as well now. So that will follow process as well. The reason for not going to a tender is outlined there.
Thank you. And this has been through Finance Committee, I see.
Oh, yeah, and there's others as well. Sorry, yeah, on pages 2 and 3, which all gone through due process.
Any questions about these items? No. Thank you. Use of the trust seal. Use of the trust seal.
Thanks, Pat. So the Trust used the seal to firstly complete its lease with W. Smith Limited for the proposed new Marks and Spencer's and W. Smith units on both Epsom and St Helier site. So we now have leases in place, and during February and March those new units will be opening for our patients and staff. And then the other main reason for the use of the trust seal was regarding the land transfer and disposal of the Sutton Hospital site.
Thank you. So we note that report. And we come to any other business. We go around the table, Richard. Any other business? No? Very well, that's the end of this meeting, and as you will realise, we've got through it quickly, and that's partly because we have a very heavy private board to follow, so that's a good result. But we do have we have a quarter of an hour for questions. The next public briefing will be at St Helier Hospital on the 16th of March, and the next public board meeting on the 13th of April at Epsom. So I'll close the meeting and ask for questions from the floor.
Thank you, Charlotte, for finding a room. I'm still concerned about inpatients being taken out in the open in this weather for ECG, couldn't they go down to the pre-assessment and so that they're kept inside?
Possibly, it depends on what tests they actually need. Sometimes they might have to go to the ECG department. I can talk to you afterwards if you want, and I will find out and I'll come back to you.
I think...
And also in the paper, they put claims against the trust 2 decades ago. There was a large article in the Guardian, I think it was 2 weeks ago. Now, as the trusts weren't joined, are these charges separated between Epsom and St Helier?
So Bess, it's sort of kind of a bit academic, because the way this now works is that there's this thing called NHS resolution, which is the part of the NHS that processes all the claims for things that haven't gone right. And every year, we now pay like an insurance premium to NHS resolution. So and hopefully what we pay in is less than what they pay out. So it's a bit of it's a non-question now, because just Epsom and St Helier pay an insurance premium essentially to NHS resolution, who then manage all of this on our behalf.
And the last question is, with all the changes going on at Epsom, I think it's not patient first. The poor patients are suffering. They can't find out, I know they're signposted, but they can't find out how to get into A&E. They come in the side door. I know there's a door there that says it, but they think it's a private office. And then sometimes they're sent round to the double doors. Sometimes it's got staff only, and other times it's got a notice up saying, press the bell and enter here. And other times they end up where we are, saying, where is this A&E? And then when they have to go down Swelliot corridor, they're very confused as to where they go. And again, they end up by the lifts. Can something be done to signpost it more? And about letters going out saying, you have an outpatient appointment at Epsom Hospital, but not telling them where.
Trevor, could you take the first point about signage?
Yeah, sure. So Beth, I think we recognise it's very challenging for patients at the moment at Epsom. We're doing a major redesign of our urgent care facility. We've moved out the paediatric outpatients, and there's a vast amount of space, and there's an awful lot of reconfiguration required in order to get the final design. And I think at the moment we're actually moving the entrances as well at the moment. So I think we've done an awful lot of work around the signage, temporary, but it is quite painful, I get that. I think I'll work with my communications team, colleagues as well, in trying to see what else we can do and whether we can work with some volunteers about maybe providing some guidance for people as well. But it's a moving obstacle at the moment, because we are moving entrances and all that, and we've probably got another 6 to 8 weeks of that before we've completed. But we will try the best we can.
I don't know whether people are having a go and taking the signs down.
I hope not.
We
we spent a lot of time in trying to do that, but I appreciate it's not ideal in terms of a clear, visible entrances, etc. We are trying to help that, but I think over this weekend there's some more work happening that will improve that.
And the outpatient letter point was?
I can pick that up. We'll go away and have a look at what the outpatient letters actually say. It may well be that because of Trevor's talked about the and some of the outpatient facilities have just moved as well, which won't have helped the facility. So we'll go and see what we're reporting to people.
We absolutely recognise, Bess, that it is very difficult for patients and difficult for staff too, and that's the price of trying to make the facilities better for everyone. But
if asked where certain places are,
yes, no, it's very challenging. Thank you for raising.
Can I just some feedback from the front line? I think it would be really helpful if actually when we're looking at the signage and we're looking at the next stage of how we direct patients, to actually see if some of Lisa's kind of patient group could help us with that, because I have to say it was only when a parent described their journey and where they park to me that I began to walk through the journey in their eyes rather than my own. So I have to say, though, the feedback universally, and I speak here from a paediatric perspective, is it's a fantastic facility, and actually people are very impressed with the changes that have been made, thanks to Trevor and the team.
Bob.
So
Bess's second comment about the money that you're getting people having to go at you for, right? For me, this article that I read, I'm saying to myself, there are a lot of cases where the public won't take the effort to make a complaint. They won't take the effort because they're in cloud cuckoo land as to what has happened. So, and personal experiences, or I had a pal just recently. Epsom Health and Care had sent this chap's wife to Guildford for an MRI. She has an MRI at Guildford, the results don't come back, right, for a month, right? In that month, she has a major stroke. The results from the MRI showed that she had had mini strokes, yes, previously. And so what's the tie-up? And this chap, I said, you really have to write it down and you need to take them to task, right? Because this is the only way they learn. But he is devastated that his wife has died. He doesn't want to go and do that, right? But it's costing a lot of money, this. You're not getting charged for it, but, you know, that MRI was wasted, yeah? Sending somebody to Guildford. Anyway, I've said enough, I think, and I can come up with quite a few cases like this, not immediately, right, from current, but this was current, so this happened over Christmas.
Okay, but
there has to be some tie-up between Epsom Health and Care, yeah, and what happens at the hospital.
So, Bob, perhaps we could touch base at the end of the meeting, and if the gentleman would be willing to share details, we can look into what's happened here, because it is really important that we actually learn from if and when things haven't gone right, so that in 20 years' time, if you like, the infrastructure we have and the payouts that are seen nationally are something that actually is not active and has changed significantly. So I'll catch you at the end and we'll have a catch-up.
Thank you, Bob, because it is important that we do hear about these things. And you're quite right, lots of people don't want to be complaining when they've gone through something as devastating as that. So thank you. Maurice.
Thank you very much. This relates to somebody contacted me about just before Christmas, the week before Christmas. Person was admitted into your A&E department. Your chaps saw the person within 4 hours. Your chaps decided that the person had to go to another hospital within 4 hours. Within 4 hours they found a bed in another hospital. But it took 30 hours for Sutton Social Services to come down and okay it. Now, has that been a problem for more people than the person that spoke to me?
So a bit like Ruth's last comment, it's really hard to answer the question without knowing the data, the information. You can't share it publicly, so we need to go and have a conversation. But in general, the response we've had this winter from Surrey, Sutton and Merton Social Services has been absolutely...
I'm not talking about Merton, I'm talking about Sutton.
No, yeah, but I'm saying the response we've had from all 3 of the local authorities we work with for social care has been absolutely fantastic, because they have had to cope with a huge number of increase in referrals and then looking after people too. So, but we'll have to look into the specifics, which we can get afterwards.
I'll write to you on it with more detail.
Claire? Hi. Yeah, I have a question for Daniel, really, as usual. You won't be surprised. Obviously, the situation in the hospital over Christmas has been a nightmare for the staff, but as you said, it's been much better here than elsewhere. But what I want you to tell me is, what are you doing to feed back to NHS England and to the local politicians and to Jeremy Hunt that this situation cannot continue, that the trusts need more money, that they need to be able to pay their staff more to attract them? What are you doing about that? Because at the moment, all of you are firefighting, and the situation Rajesh mentioned about losing funding because you can't hit the targets, that to me is obscene. What are you doing to to address this situation with the powers that be?
So we state our case, I think, very clearly and effectively. One of the reasons why we need a longer private part is to talk about that very issue and what response we might want to make as a board to our regulator, because I think we would share your sentiment, which is having funding taken away when we think, whilst absolutely we haven't delivered the standard, but relatively we're doing really well, is not, doesn't feel as fair as it could be.
It's obscene.
It's important to us, but of course the other thing we're arguing for very hard is to properly get into the capital pipeline to get the £400 million we need to build a new specialist acute facility so that we can care for everyone in the appropriate facilities and have the appropriate staffing for the generations to come.
Again, that's just firefighting. We need 2 places, you want 1 because of the staffing situation. It's crazy. We should be, fighting to have the proper facilities in both places. That's what we need you to do.
So what we believe we need to do is argue for having the single specialist acute facility, because we believe that's the right answer to provide high quality care for the future, and we're working to get the in-principle decision in funding for that, so that we can then have a consultation later in the year about the right location to have that facility.
But we will be discussing what we say in response to the fact that our funding has been cut. So thank you. Sandra.
On a similar subject, I mean, it's been said here today that you're running hot and you're on the edge. I've heard that there were a 7-hour wait yesterday morning in A&E. Apparently 200 people at one time in the week of the 14th of January, 200 people were in a queue for an ambulance. So things are really bad. But you tell us that although it's really bad and you're on the edge, you're doing much better than all the adjacent trusts. And the figures in your report show that you're doing better than them. Now there's a serious anomaly going on here, because in the minutes of the last meeting, you said that in scenarios where the catchment would reduce in terms of population, fewer of the available beds would be provided by Epsom and St Helier, and more in neighbouring trusts. Now, all of your scenarios entail a reduction in catchment, every one of them. So what you're saying is in all of your 3 scenarios, you would rely on other trusts providing beds for the catchment area we currently have. They are coping less well than you now. Can you explain to me how you think they are going to be able to suddenly up their game in one of the scenarios by 40%, and you are going to cut your beds by 40% in one of your scenarios when you've promised us you're going to keep them the same? So there's a lot of contradiction in what you're saying here. You've said repeatedly we keep the beds the same.
I think we've asked the question. There's a question there. Let's have a...
So when we get to look at the criteria by which you would choose which is the best scenario, one of the criteria will be about what is the impact on other hospitals, and does the local NHS think there is realism in the impact on that hospital actually being delivered and keeping good patient care. And on some of the scenarios, as you have seen, there is a really big impact on other providers, and so that assessment has to be done very rigorously to enable us to be able to say that the quality of care either would not go down, stay the same, or be enhanced. The thing that's so important, and it is the starting point of all of this, which is we are absolutely sure that we can't carry on with the service configuration that we have forever, because no matter how we try to do it, we could not fill the staffing gaps. We cannot deliver the quality standards that we have been set in the service configuration that we have. So there has to be some change, and we hope that we are putting on the table for the commissioners now, because we've passed on, we've produced our strategic outline case about what we think as a hospital the right answer is, and we're now saying to the people who buy our services, do you agree? And do you want to get into the place of consulting the public, that we're putting on the table a big investment that will secure great healthcare for the future. So the next stage is, do our commissioners agree? So it may be that the conversation we're having, we don't need to pursue because there isn't an agreement.
I'm saying, Daniel, in all of this process, you have a duty to ask the public to be absolutely straightforward, honest and upfront about what your plans are. Because until I read that statement there, and I would suspect most of the public read that statement, you don't make it clear that you intend to cut beds in your scenarios by up to 40%. You have said repeatedly that we've got 1,000 beds, we'll keep 1,000 beds. That's patently not the truth. Why haven't you made that clear in your engagement?
So I beg to disagree completely. So if you look at the strategic outline case and you look at the tables that have beds, you can see that in each scenario, the number of beds provided in the Epsom St Helier sites and the number of beds provided in other providers, and you can see that the total number of beds is pretty consistent across the three scenarios
Daniel,
to what we have.
you never mentioned other providers when you were talking to the public.
So I'm pretty sure that I did, and I'm pretty sure that I have stood up in plenty of public meetings and explained it when asked, and I'm pretty sure you can see that it is explicit in the strategic outline case.
It was not mentioned in any of the documents that you asked people to sign.
No, it wasn't.
It wasn't there at all. You didn't disclose that until afterwards.
It was in the strategic outline case, but
Yeah.
you've made your
After.
After the engagement.
You've
Totally
made your
misled
point.
the public, and you claimed broad support when there was none. 400.
And I suspect
Sorry.
most people don't realise that that's the plan now, but we in Kosh will do our best to make it clear that that is the plan.
Okay. Any other questions?
Yes. When are you going to announce your provision for the 6 acute facilities that you're only promising to keep going till 2020? You have said over the last few years that you are committed to continue providing the 6 acute facilities until 2020. You have not made any announcement about how those services are going to be provided post 2020, other than to say that you hope that you'll get 400 million to build a new specialist acute facility either in 2024 or maybe now 2026. What is your plan? Where is your budget for those facilities post 2020?
So if you remember, the first thing we said when we produced our SOC and in the November public board meeting was we were going to keep our commitments till as long as we got to a single acute site. That was the first thing we said. So I think we could not have been more explicit about that either.
When that question was put to you, you said you're sure that morale would get a tremendous lift if you got the 400 million and staff would make every effort to keep things going. That was the sum total of your assurance.
The assurance was also that we would keep going until we got to the position that we had a single site.
You haven't published that at all.
The time is up, I'm afraid, for questions, unless there's one last one from someone else. Yes.
Can I just ask something I'd like to understand, and it may be something to come back to another meeting. One of the key problems is the staffing levels, and that's why you want one acute site. What are the staff going to be who are going to be staffing Epsom Hospital and St Helier Hospital once you've got all the presumably senior nurses that you're short of? Will they all be going to the acute site, and will it be healthcare assistants at the outpatient clinics and the rehab beds left at Epsom and St Helier? Just like to understand.
So it's a very long answer to that question. The short answer to the question is all the services in all the locations we're proposing will be appropriately staffed by the appropriately trained people. And we have done quite a detailed staffing model to work out how you could do it, and we are confident that we can. And it does mean an investment in some more groups of staff. So we would want some more types of doctors, some more types of therapists and nurses to do the rehabilitation part of the journey for patients. And we are confident that those staff are able to be recruited because when you look at services like Epsom Health and Care, where we put a new group of services, a new service model together, and we said, we're all going to work together as one team in the health system to provide better care for older people. And we started with 100% of vacancies, and we currently have 0% vacancies because the model of care that we have put together, people want to come and work for and do, because it is a good set of jobs where people get a lot of job satisfaction. And I'm equally convinced when we launch Sutton Health and Care in April, we're going to have the same impact there. So the vacancies in quite a lot of the community services are at 20%. But I think we'll be putting together a service model that's attractive, and people will want to come and work, and we'll be able to do the services that aren't the 6 specialist acute ones, as well as we will be able to do the specialist acute ones in the future in the model.
Thank you. Thank you very much. I'm going to bring the meeting to a close. Thank you all for coming, and we'll see you next time.